Thank you for coming to tonight's clinical case webinar. This is a life without Sublocade, and tonight we have Dr. Hester Wilson, who is the Chief Addiction Medicine Specialist in New South Wales at the Ministry of Health, and also Dr. Jenny James, who's a GP specialist who are both joining us for tonight's webinar. Dr. Wilson has also been working on the guidance for Sublocade for New South Wales. And I'd like to invite Dr. Wilson to give this acknowledgement of country and the recognition of lived and living experience.
Thanks, Jess. I'd just like to acknowledge that we're on Aboriginal land. I'm dialing in today from Gadigal land, and just acknowledge the disproportionate harms that happen for First Nations people, Aboriginal and Torres Strait Islander people, in terms of drug and alcohol issues that is related to colonisation, dispossession and intergenerational trauma. I do want to pay my respects to Elders past, present and emerging, and any Aboriginal or Torres Strait Islander or First Nations people who are with us tonight. I'd also like to just make a recognition of lived and living experience. And just to, there's an echo happening, Jess. I'll keep going. Just a recognition of people with lived and living experience of drug and alcohol use, and also drug and alcohol harms, and acknowledge their resilience and their expertise and the role that they play with us as advocates and activists, and a lived experience workforce that I know as a practitioner help me absolutely immeasurably to do my job and to do it well and to assist the people that I see and the people in our communities. Thank you so much.
Thank you, Hester, for that recognition of lived and living experience and acknowledgement of country. So I just wanted to share some of the demographics of who is registered for tonight. Really interesting. We have over a third of participants who are from other states other than New South Wales, but about a third of our metropolitan and a third are regional who are joining us today, as well as many GPs and pharmacists, as we expect, but also lots of nurses in nursing roles and nurse practitioners. It's really great to see, and allied health. So thank you everyone for joining for tonight's webinar. I'm very excited to have Hester and Jenny coming to speak with us. And a little bit about the OTEP case webinars, in case you're not familiar. The OTEP is the Opioid Dependence Treatment Education Program at the University of Sydney. It's funded by the Ministry of Health, and we hold monthly webinars. They're typically case-based webinars on Tuesday nights. If you do attend live, we'll email you a certificate of attendance, which you can use to claim CPD points afterwards. These webinars are also recorded and made available on the OTEP website if you'd like to view it at a later time. So just some quick housekeeping before we start. Please keep yourselves on mute. If you would like to ask any questions, please feel free to put them in the chat. Jenny will be monitoring the chat tonight. And as I've mentioned, the webinars are recorded, so don't reveal any identifying information. But yes, please feel free to interact. We're excited for a great webinar tonight. So I'll hand it over to Jenny now. Thank you.
Great. Okay. Thanks very much, Jess, and thanks, Hester, for the acknowledgements. So, yeah, I'm Jenny James, GP, member of the RACGP Special Interest Group for Addiction Medicine, just giving that a bit of a plug. That's something that Hester chairs. My primary role at the moment is at South West Sydney Drug Health Services, and I basically there to help GPs gain confidence and experience when they're working in the addiction space in a GP setting. And in the ODT space, I'm usually working with GPs who are not OTEC accredited. They might be just beginning their journey on prescribing injectable buprenorphine, or they might just have one or two or three patients on Sublocade or Buvidal. But just recognising, I'm sure we've got a huge amount of experience in the room as well, from people who have got a huge amount of clinical experience and through to people who might just be starting out in this area. So this webinar is for everybody. So the outline is here. So what we're going to be covering this evening is a background to the discontinuation of Sublocade. So why has this happened, and when did it happen, and is this happening in other countries? And we want to spend a bit of time talking about the important issue of preparing patients for this change, and I'm sure that a lot of you have already been doing that. But also talking to the administration points, the pharmacies and the clinics, having conversations with them, and making sure that there's an integration between, prescribers and pharmacists who are delivering these medications, planning so people know where people are at. We'll be talking about the pharmacokinetics of the two forms of long-acting injecting buprenorphine, so Sublocade and Buvidal, and also taking a look in at the pharmacokinetics around the sublingual formulation of buprenorphine. And also, you'll be seeing the New South Wales Health Guidelines, which are about how to transfer people from Sublocade to the other opioid dependence medications, or perhaps for people who are ready and wanting to complete treatment. So those guidelines are not quite available yet on the New South Wales Health website. They should be out fairly soon, but you are getting an excellent sneak preview of them tonight. So we'll be discussing all those issues around transfer. So just the final thing, really want to encourage you to put all your questions and your queries and your comments into the chat there. There is no question that is too small or too little or too large. So at this point, I'll hand over to Hester, and we can hear a little bit about the background to why is this happening, Hester? Oh no, we've got the polls. Back to Jess, actually.
So I've just launched a poll. There's 2 questions there. So if you only see one, scroll down and answer the other one. And once we've had some participation, I'll share the results. So Hester and Jenny and the rest of the participants can see how people are feeling about this change. Okay, Jenny, you should be able to see the results.
Yeah, so poll 1, that's the question about how concerned are you about managing the transition of Sublocade in your setting. So 42% of you are somewhat concerned and 11% very concerned. So that's telling us that over half of you are concerned. 17% of you are neutral. 22% of you are feeling somewhat confident, and 8% of you are feeling very confident. Okay, so a mix of views there. And the next poll is about how concerned are your patients when you've had conversations with them. So very concerned, 24%, somewhat concerned, 45%. So 45, 65. So that's a lot of you are saying that your patients are concerned, very, or at least somewhat. 15% of you are saying they're neutral. 15% is saying that your patients are somewhat confident. Nobody has said that their patients are very confident. So certainly on that question, there's a strong view that you're all expressing there, that your patients are expressing concerns about this.
So I've just stopped sharing the polls and I'll hand it over to Hester.
Thank you. Thank you. So why is this happening and what has happened? I don't know if anybody else had advance notice of this, but this came as a complete surprise to me in early July, that Indivior had made a commercial decision to withdraw Sublocade from Australia. It wasn't about safety. It wasn't about efficacy. It's about making money. Pharmaceutical company, they're there to make money. It is also affecting other countries. So Sublocade has been removed from other European countries, and there's also some information that suggests that the sublingual formulation has been removed from other countries. I am told that that is not the plan here in Australia, and given that it's been in Australia for quite some time, I think that that is unlikely. But, really, we are at the whim of financial decisions made on the part of a company. So we are in this situation. Going on to the next slide. And so from the 31st of December, it will no longer be available on the PBS. Look, hypothetically, you could do a personal importation through SASB, but it's expensive. That will be expensive, and there are a few people who could be able to afford that. The idea of doing a Reg 24, where you try and get 6 months supply before the end of December, potentially. I just want to flag that, though, PBS will finish in December. So you'd need to talk to your pharmacies about accessing those Reg 24s before that. Otherwise, pharmacists will not be paid for it. Next slide. How many people do you have on Sublocade in your service? I'd love you, if you just want to put in the chat, how many have you got in your service? Certainly, the information is in July 2026 that Australia-wide PBS claims for that month were 3,300. And for the year before, April, 42,000 for the year before that. So that's around about 3,500 people through PBS. I should acknowledge that some custodial settings, depending on your jurisdictions, may not be doing this through PBS. So that it's not the full number. But what I'm seeing down here in the chat, let me just have a look. Small numbers. Alison's saying 50, Trish 14, 25, 3, 6, 5, 8. Yeah. So the numbers are not large.
Well, Bronwyn's coming in with 100 to 150.
100 and 150. Bronwyn, where are you? Which state are you in? Love to understand that a bit better. Frankston. Okay, so down there in Victoria. So yeah, you guys in Victoria, you were very enthusiastic uptakers of Sublocade. You know, great when it was available. Unfortunately, it means a huge change now. So I do want to just make a flag that there has been some advocacy done on the part of state jurisdictions and for us in the College GPs and the College of Physicians, conversations with the federal government, and really the feedback that we're getting is this is really tough. However, we're not in a position to do anything about this. We are aware that there's also been the changes of the tamoxifen, no, not tamoxifen, yeah, tamoxifen for endometriosis, and some insulins that have been removed as commercial decisions. And I suspect we might see more of this. And it's really to do with the situation that is happening in the US with the current administration, and there are sometimes interesting approaches to how they work as government. So I think we do need to plan for this, that this is going to be something that's going to happen. Sorry, Jess, can I just get you to go back for a sec? That this is something that is going to happen. And we've seen from your responses, and I know it from the people that I interact with, there are concerns, and there are concerns on the part of our patients. And we need to be sending a calm message, acknowledging that this is really disappointing on the part of this company, but at the same time that it will be okay. There are other options. We will work through this together. I know it's really easy to get caught up in the frustration of it, and it's okay to express that frustration, but also really flagging this will be okay. We will be able to manage this. I do want to acknowledge that when I think about the two the groups here, it's the people. There are two groups: the ones that were started on Sublocade as a first line. You know, so people that Sublocade was around, we tried it, it works for them. The other one is the people who potentially tried Buvidal, but then that didn't really work for them, and so they moved on to Sublocade. And we would have potentially more concerns, and our patients would have more concerns if they were in that second group. And I think that's really important to acknowledge. Moving on to the next slide. So just in terms of thinking about what happens for people when they see Sublocade, first of all, it's got a half-life of 42 days, so it continues to be released for months after the last dose. And people may not notice any withdrawal for 2 to 4 months, and that may be mild. And quite often that withdrawal will tend to be cravings, mood, and sleep disturbance more than the other withdrawal symptoms that we might see with other opioids. And I do wonder if some of that craving and mood and sleep disturbances might actually be partly because of how you as the person that is stopping this treatment feel about it. That is an important dynamic that happens. That, I've no longer got treatment. What does that mean for me? And so for me, that really does once again flag the importance of us sending a really calm, confident message of, we've got you, this will be okay. The other thing that will happen is that you will continue to see Buvidal in people's urine drug screens for months. So that's an important thing to flag for people so that we're not misinterpreting those urine drug screens. Moving on to the next slide.
And
Yep.
just before
Yep.
we move on, I know
Sorry,
that that's all right. We had some questions that came in before the webinar, and I remember one of them was a question about the half-life for Buvidal. So just comparing that to Sublocade. So Sublocade's there at 42 days, and Buvidal's what, about 19 to 25? Or
Yes.
yeah.
So it's a little shorter, and that is an important thing that we'll talk a little bit more about. Absolutely. Yeah. So this next slide, I think the important thing about thinking about transferring from Sublocade to other options is that there's no published research on this. There is some PK data. Okay. Now, I was away from uni the day we did PK data, so I'm a bit thick with this stuff, so I'm just going to explain it in the way I understand it. I'm sure there's some people on this webinar who get this stuff a lot more than me, but hang with me. So just looking at this slide, what we've got on the left is we've got your sublingual buprenorphine, we've got Sublocade, and then we've got Buvidal weekly and monthly. And what you can see with the long blue columns is the steady state in nanograms per mil. So it's not after the first dose, but it's once that dose is stabilized after a number of doses. And if you look, for example, if we look at Subutex 32 milligrams, the sublingual buprenorphine, you can see that column is quite wide. So at the top, it's 15.63. At the bottom, it's 1.98. And then there's another little number there with a little white line, which is 3.68. So what this means is that there's a wide range of serum levels, but the mean or the average, the one that most people will settle around is the 3.68. So if we look at Sublocade, you can see that middle line is 6.32 with an upper of 11.81. So it's a little less. The range is less wide than it is for the buprenorphine. Buvidal weekly, if we're looking at the 32 milligrams, 4.17, and for the 160 milligrams of Buvidal, 5.27. Okay, so one of the things you can do when you're thinking about the dose, and this is theoretical, because we don't have those clinical trials that have been published, is to look at how do they compare. And so if you for example, if you look at Sublocade 300 and compare it to Buvidal 160, you can see that overall, you may notice that the overall serum level is going to be a little lower for Buvidal. But if you look at the range, there's a possibility that it will be higher in some people. So this is where some of the complexity sits. If you look at a comparison of the Sublocade 100 and your Buvidal 24, it's pretty similar, for example. You look at the 96, it's pretty similar. But this is as I say, there aren't trials. So what we're doing is we're looking at, well, how does this compare and what do we think? So this is consensus guidance that we put together in New South Wales. And I know my Victorian colleagues have been working on a similar document. But really important in this is your clinical assessment and your ongoing support of your patient to make sure that what you're doing is supporting them so they don't go into withdrawal, but also supporting them so that they don't get any side effects from those higher doses of buprenorphine. Now, while those high doses of buprenorphine in most people are unlikely to cause an overdose or real harm, they can give people quite unpleasant side effects, agitation and anxiety. And some of you may have had patients who, when they went up to those bigger doses, the buprenorphine sublingual 32, they really noticed that. The other thing, so just looking across those and thinking about them, I'm just trying to think what else I haven't said that's important. But keep that in mind, and that is available, and you can see it when the guidance finally comes out, which I'm hoping will be very, very soon because it's the final stages of sign off. This will be available on the New South Wales Health website, but it's also currently available as part of the long-acting injectable buprenorphine guidelines in New South Wales. And Jess, we can send everybody a link to that if they want to go back and have a look at this figure. Any questions, Jenny? No. Any questions from you, Jenny? I'm trying to.
No. Well, just a comment, which is, of course, this is about steady state levels, and
exactly.
Of course, is not about duration of action, which is the other part of the story, which we'll be coming to.
Exactly. Okay, moving on. Okay, so how do we do these transitions? First of all, don't panic. It will be okay. Yes, the guidance from New South Wales will be out soon, as I hope our Victorian counterparts will have theirs happening as well. What are the transfer options? I mean, basically, you've got the other long-acting injectable buprenorphine, you've got sublingual buprenorphine, you've got completing treatment. And as Jenny said before, there may well be some people who are at a stage in their lives where completing treatment is absolutely on the cards. Methadone we'll talk about, theoretically possible, but we'll get back to that. Moving on to the next page. So Sublocade to Buvidal. So Buvidal is the alternative. It's the same medication. You can reassure patients that it is the same medication and it is long-acting. Give the next dose when the next dose is usually due. So if the person usually has their injection at 3 weeks, give it at 3 weeks. If it's 5 or 6 weeks, give it at 5 or 6 weeks. And Buvidal has a shorter duration of action from 3 to 5 weeks, and you may find that you need to give it more frequently. The thing that you want to do is you want to be, first of all, thinking about the attributes of your patient. So if you have someone who has significant comorbidities that can adversely affect respiratory function, so significant cardiorespiratory illness, sleep apnea, obesity, these things would suggest that they are at increased risk of overdose because of their respiratory function. Or if someone is using other high-risk sedatives, lots of benzodiazepines, lots of other sedating medications, presenting with intoxications, presenting with toxicity or overdose, then you'd want to be more cautious. So what we're suggesting in that group is go for the 96. If somebody has been on long-term Sublocade, and as I said before, they're in that first group where they just started on it and it worked for them, go for the 128. If there's somebody that's recently transferred to Sublocade from 160 milligrams Buvidal, they're in that second group where it really didn't work for them, go for 160, as long as they're not in those higher risk groups. Now, I should flag that this, once again, is not supported by clinical research and clinical data, but it is our thinking. And certainly I was in a meeting today with some of my colleagues working in the custodial settings around Australia and just asked them, what doses are you using? And most of them are going for 160 without issues. But it certainly is fine to go for a lower dose. Keep checking in with your patient. And if it's really not, if they're having withdrawals, then you can add additional Buvidal in on top.
So just checking in with the group there. There's no comments I can see, but it's a fairly busy slide. Has anyone got any questions, or does that sit? To me, that sits very comfortably, makes good sense. Looks clear to me. Any questions at all or comments anyone wanted to make at all? Looks quite
Thanks, Trish.
Clear. Good. That's nice to know. Thank you.
Yeah, so just thinking once again, of course, with the Sublocade 300, we wouldn't go Buvidal weekly. And if you can think back to that chart that we looked at before, it's just not going to give you the levels that you would be looking for going from a Sublocade 300. So the monthly is better. For Sublocade 100, you can use the weekly 24 milligrams Buvidal or 96. And certainly talking once again to my custodial colleagues in Queensland, they were saying, look, they do have people on 100 and they would choose either 96 or 128 and they haven't had any issues. Those are small anecdotal reports, I should flag, but really it's going to be okay. It is important to review patients regularly, and that's a clinical decision around the particular attributes of your patient, of their level of anxiety, of really making sure that we can support them. Checking for the dose effects, really thinking about, are they having cravings? Are there withdrawals? Or are there side effects that suggest that buprenorphine dose might be a little high with some agitation, headache, constipation, etc. The thing is, though, that what you will find is you'll have that increase and then it'll drop. So it may well be just kind of saying, okay, so it's not 100%, let's just sit with it, see how that dose goes as things stabilize out. Because the issue that you have with a Sublocade is, you've got the 300 milligrams steady state, and as it drops, it's going to drop slowly. And so it's the issues around, is it going to be too high a dose, are short term. And as the dose drops, they will settle. Having said that, as I say, if you want to start on that slightly lower dose, go a bit more cautiously, see the person frequently, you can add some extra doses on top to help keep them in that steady state. And please seek advice. Don't feel like you need to do this on your own. If you're hugely experienced and you're working in a multidisciplinary team and you've got lots of support, that is absolutely fine. But don't feel like you have to do this. Get some support. Call your jurisdictional drug and alcohol specialist advisory services. Call your go-to people that you go to for advice. You do not have to do this on your own. I think I've covered that, so I've just got to let the cat out.
So any questions from anyone at all? No, that's good. You must be all comfortable with that.
Beautiful. All right, moving on. Sublocade to sublingual buprenorphine. Now, moving from sublingual buprenorphine to the LAIBs is super simple because it's a daily medication. The other way is a little more complex because, once again, we're talking about the same idea that you've got this high dose that's going to drop off, but it doesn't drop off suddenly, it drops off over time. So the usual thing that we would do with sublingual buprenorphine is generally start people on 8 and get them up quickly over 2-3 days, to 8, 12, 16, 24. We know that that's important in terms of if you're shifting from short-acting opioids to retain people in treatment to actually manage their withdrawals. We did have some problems back in the past where we were thinking, oh, methadone, you've got to start low and go slow. And we were doing that with buprenorphine, and that wasn't great. You don't need to do it the same way. But in this situation, because you've got that high dose buprenorphine, you can go a little slower. So start with 8 milligrams when the next Sublocade dose is due, and frequently review and titrate over days to weeks. So you might think, well, let me just go 8 milligrams and just keep them on 8 milligrams for a few days, and then we can look at whether they need to go up a bit and titrating it up as they need. And with the likely dose that you will need around about 24 to 32 milligrams. But you can go a bit more slowly because that dose is dropping off. Same with the Sublocade, somewhere between 16 and 32. But likely to be a slightly lower dose. Once again, checking in with people. How's it going? How is it holding you? Are you having any withdrawals or cravings? Or are there any side effects that suggest that this dose might be a little high for you? The other thing is, don't assume that everybody needs daily dosing. If somebody's been super stable and working, and not coming into the pharmacy or into your dosing clinic every day, you don't automatically assume that they need to. You can certainly, if somebody wants to come in and have that extra support as they change over, absolutely. Or you can do some virtual or phone support, or do it through your pharmacy, and certainly with people who are very stable, I'm very happy to have conversations with them where we kind of liaise over the phone and they manage their medications at home. Really, but once again, just flagging, it depends on your jurisdiction, what you can do in terms of takeaways. I'm talking from a New South Wales perspective. Once again, get advice, talk to your drug and alcohol specialist advisory service, talk to your local drug health services. Don't hesitate to ask. But it's once again, it's just that thing of working collaboratively with your patient, collaboratively with the pharmacy or the other with the dosing points, and just slowly, settling that over a period of time. Any
Okay,
questions there? No
no
questions?
comments, no questions. No, okay.
Moving on. Sublocade to methadone. Now, I've thought a lot about this, and once again, theoretically, you could do it. In the public setting, we wouldn't be able to do it just because of the time and staff impact that would have. I can see how I might do that in a private setting as a GP where I'm seeing people, I might just decide to see them daily and check over time. But once again, it's going to take quite a bit of time to get that dose right. And so when I think about it, and as one of my Victorian colleagues said, it's going to be a bit of a wild ride. I'm not into wild rides for starting people on opioid dependence treatment. I like it to be kind of calm and steady. And so really where we ended up saying, look, get them onto a stable dose of sublingual buprenorphine, and if methadone's where they need and want to go and it's appropriate for them, then transfer at that stage as you normally would.
So any questions about that? I mean, I guess as a GP, just consider transfer to methadone after some weeks to months on daily sublingual buprenorphine. I know we can't put numbers exactly on that, but we'd be looking at something in terms of a minimum. I would be thinking of it at least something like 6 weeks of Suboxone treatment as a minimum. That would be the sort of,
Yeah. Well, when you think about it, that people will start to have withdrawals from Sublocade at 2 to 4 months. It's a slow, steady process. And Bronwyn, that's where I got to. Sorry, Bronwyn's just saying Sublocade to methadone sounds tricky.
Sounds tricky.
You could do it, but you'd have to be really careful because you've just got that risk of a pure agonist, a quite potent pure agonist on top of a high dose Buvidal potentially causing problems.
And Alison's just saying that so far none of her clients have requested transfer to methadone.
Yeah. Look, and I think for the majority of people, they're going to want to go, look, I'm happy on a long-acting injectable. I want to stay on one because it means I can get on with my life. And I think that's where the majority of people will go. But, it's really just, I think one of the important things, particularly in a situation where we as prescribers and our patients have had no choice over this change, it's really important to be thinking through what are the options that we still have to allow people to just kind of think what's potentially going to work best for them. On to the next slide. Completing treatment. Sublocade is a brilliant medication to complete treatment if people are ready. And that's the important thing. So for me, and having done a lot of this in general practice, helping people to complete treatment, it's a slow, steady process. And the long-acting injectables are an absolute gift because that slow decrease over time, quite often people have no or very little withdrawal. And so if people are ready to stop, if they're housed, their other health issues are stable, their mental health is stable, they've got good connections, they're not actively using, other drugs, or there's not other issues, and they really feel like, look, I've got this, I'm ready to have a go. It is absolutely an option to just say, let's just let it wash out of your system over those months. The important thing from my point of view is to not say, see you later, you'll be right, but to say, let's see you. Let's have a regular appointment to check in on how you're going. And let's have a low threshold to actually put something in place if you're finding that you're craving, that you're thinking about using, that you're destabilizing, that you're having a little touch of heroin when you don't want to do that. Let's have a low threshold for restarting you in other treatment. The other thing is, of course, yes, there is a risk of relapse. Do think about harm men. Think about your take-home naloxone, and really support people through it. I've been my patients, a number of my patients in general practice have been super successful at completing treatment and haven't looked back. Some of them have been successful for a period of time and then come back and said, actually, I need to restart. So really flagging to people, there is a risk. If you're worried about it, at any time we're here to support you. This quite often is a long-term treatment. What long-term means is different for different people. And once again, if you're not sure, seek advice. Don't try and do this alone if you're not sure.
Any questions about completing treatment from anyone?
So one of the things that we might do with completing treatment is look at a dose reduction, so potentially going down on the dose, increasing the injecting interval, transferring to Buvidal, so that once again you can do that completion over a longer period of time. And with those, that's a clinical decision, and you quite often with patients, they get a bit of a sense for how long that medication lasts them. So they've had a situation where they were a bit late with the medication. They know when they start to notice it. You can use that information, each time you're talking to a patient to try and plan this completion. Moving on to the next slide. So here's some case studies. We've got about 20 minutes. Now, these are hypotheticals and they're pretty general. And I really want this to be a time for conversation. I don't pretend to be an expert in this area. And I know there's a lot of expertise in the room. So really want your thoughts, your ideas for us to talk about. So Jay is 35, history of heroin injecting in the last 10 years. He's had methadone in the past. He ceased after 3 years. He cut down probably a little bit earlier than he should have, but he was busy off working and didn't want to stay on it. But then he relapsed to heroin and recommenced on Sublocade, 300 milligrams monthly, and he's been on that for 3 years. So he started directly on that, and he attends his injection every 5-6 weeks. He smokes tobacco, uses some cannabis, some occasional ice with friends, doesn't drink. So, but from his point of view, the other drug use, yeah, he'd like to give up smoking and he knows he should, but he's not at a point where he wants to do that. And his cannabis and the occasional ice is the social bit of fun, not an issue for him. He's otherwise well, and he hasn't tried Buvidal before. So if we're thinking about Jay, he kind of fits into that first group who, given the history, no other health issues, he's not someone that we're worried about high risk behaviours or other respiratory issues. And he's not someone that has failed on Buvidal before. Well, not what failed, but didn't find that the dose held them. So he'd be someone that you would probably start on 128. When he's due at his every 5-6 weeks, start him on the 128 and follow up and see how he goes. And the 128 may well be more than enough, or he might need to go up to the 160, and you'd need to give it more frequently than the 5-6 weeks. So flag with him that you're probably going to need it more frequently than that. And we can give you a top-up dose if you need it. Any thoughts, anybody on that one?
So in terms of ODT options, any other thoughts that you might have, or in terms of just communication issues that might be important for you to talk with Jay about?
I mean, he's certainly someone that potentially could be saying, look, I want to have a go at completing treatment. I'd love him to stop his tobacco and a little bit of cannabis, occasional ice, no other opioid use. He hasn't used for a long time. Potentially he could be someone that might like to complete treatment. Potentially he could consider sublingual buprenorphine.
Any thoughts from anyone? So you've got the options of going over to Buvidal, which Hester's talked about, the 128, and the sublingual is another option that we've talked about. So moving over to 8 milligrams of Suboxone as a startup dose with an increase in dose as you monitor. And go ahead.
We might move on to the next case. Please put some thoughts in the chat, or can people unmute themselves and ask a question, Jess? Is that possible?
Yes, they can.
Yeah. So please.
Great.
Talk to us. Okay, now we have Kim, who's age 52. So
Oh, hang
here's,
on. Now, there's
oh,
just a comment from Zoe. Oh, sorry, it's OENS, the question of coming off. I'm just not sure what the OENS, what you're referring to, Zoe. Could you retype that one? Oh, open the conversation. Okay. All right. So important to have an open conversation with Jay. And
yeah,
do it with therapeutic optimism.
yeah,
That we would
absolutely.
expect this transition to go well, and that we'll be monitoring Jay and going with Jay, along for the clinical journey, and making sure that we adjust things and make things comfortable for Jay. Might take a bit of time, bit of trial and error maybe, but we expect things to go well.
Yeah, therapeutic optimism. That's much better than what I said, Jenny.
Oh.
I said, we've got you. But also the importance of our treatment team. So for us as GPs, with our pharmacist colleagues, with the other people involved in care, for us in custodial settings or in public health settings or specialist settings, we're gonna support you as a team. And I think for me, one of the things that's come up for and look, is this issue around potential, and it's not the case for everyone, but for potentially for people feeling like they've not had many wins in their lives and they've not had a lot of power to decide things in their lives, to have this happen where it's another bit can feel a bit like a kick in the teeth that I've been doing well and now the government has taken, or the company has taken this away from me, and to acknowledge the distress of that, but absolutely that this is going to be okay, and that is what we are seeing from my colleagues that I'm talking to, who are doing this already. For vast majority of people, there are no issues. Okay, let's move on to the second case. So this is Kim, age 52. So Kim's a little more complex. Has a history of chronic pain and was prescribed opioids for this and ended up on large doses and started injecting. He'd had a past history of heroin use at age 19 for a few months, but it wasn't until his mid 40s that this really became an issue for him. And he was commenced on Buvidal and found the 160 still didn't quite hold him, and transferred to Sublocade 300 milligrams, and that really settled him. So this is the group that this can be really hard for. And he would be really disappointed, potentially really disappointed about the change. So to acknowledge that and to say, look, we can manage this. I think one of the important things is, first of all, to flag that, sure, he had the Buvidal didn't work for him last time, but we know with a chronic disease, chronic illness like this, that it's not the same every time. And his need for that higher dose may not be as high as it was before. This is a new story, a new part of his treatment. So we can't assume that the 160 milligrams buprenorphine won't work. It might not, but it actually might. So let's give it a go and see how it goes. The question is, if the 160 does not work for him, this is a bit tricky, and it does depend on your jurisdiction. But the other thing is that it accessed through the PBS. So being aware of what the PI says and what the PBS says is important in terms of cost to patients, but also what your jurisdictions allow in terms of what potentially could be high doses than is usual in your jurisdiction. And I apologise that I don't know across the other jurisdictions what your high dose processes are. And Ciro has said, yeah, absolutely, 160 milligrams every 3 weeks.
Every 3 weeks.
And in New South Wales, that would be what we would be saying. Let's get this happening every 3 weeks. The potential of looking at other doses, the 2 times the 96 in New South Wales. Once again, you've got to think about, does it sit within PBS criteria? Would people have to pay for that? And does it sit within your high dose kind of regulations? And certainly in New South Wales, you can make an application for high doses of medications, and that would certainly sit within that if people are needing more than the 160. We could possibly encourage, so this is Tia, we could possibly encourage Kim with more frequent clinic appointments, touch base, checking in with him, ensuring harm minimization. Yeah, absolutely right.
Very important.
Absolutely right. Yeah. Yeah. And I think the other thing, and what I'm hearing is some people saying, oh, look, we're just going to hold off till December and it's no longer available. And that gives me the heebie-jeebies, because who is around over Christmas, New Year? We do really want to make this a planned, gentle process when we've got
That's Bronwyn saying that we have a lot. She was Bronwyn's got the 100 to 150 patients. So out of that group, she's got a lot of patients who we're worrying about this.
Who worry. Yeah. I suspect, Bronwyn, that majority of them will be okay. And you're down in Victoria, so check out what your regulatory process, or you probably know it already, but you know what doses you can give, but also be aware of your PBS, authority and what would count under PBS and what wouldn't.
So just a question from Peggy, which is there a maximum dose of Buvidal, which I know is a 160 monthly, but you're 3 weekly at 21 days. That's the minimum amount of time.
Yeah.
Okay.
Yeah. So, and I think the other thing about starting it now, and that's the other thing, don't start anybody on Sublocade. One of my colleagues is still starting people on Sublocade. Don't start people on Sublocade. Why would you do that?
Yeah, why would you do that?
But yeah, starting it now, because we want this to be gentle and slow, and it's going to take that 2 to 4 months for the Sublocade to disappear out of the system. So we don't want them to be trying to do this at a time when access to care over Christmas, New Year is potentially going to be more tricky.
Oh, it's a disaster, isn't it? So Patricia just agreeing with all of that, saying we really need a smooth transition, not that last minute rush.
Yeah.
And
one of the other approaches potentially is that some people are suggesting is, hey, just wait until people go into withdrawal and then start them on another treatment. I have slight concerns about that, because it might take a bit of time for that to happen. But also, what if the withdrawal happens on a Saturday evening? I'm not around to start instituting, and getting things back into control. I think it's much better to maintain people in treatment, support them through that, see them frequently. And if they choose to say, look, I want to hold off until I'm noticing it, then that's absolutely a choice. And it may be that they want to complete, but just flagging, you've got to just make sure that, we may not be there on a Sunday to support you. And I don't really want you going into the emergency department. They're not going to potentially be able to support you in the way that we could.
Now, just some comments coming through. So Maria said we have a patient on the 160 every 2 weeks, which only just holds him. I'm not the prescriber, so don't know about the PBS arrangement.
I think that's clinically that's fair enough. You just need to be aware about your regulatory and the PBS issues.
Another comment from Uzadinma. Can we complete the cows for Kim, just considering the possible consequences? So Sure.
Cows, the complete, what is it called? The clinical opioid scale. Brilliant. I love it. It's really good because it's a combination of objective and subjective measures, patient reported for the subjective ones. It's really excellent, and once again gives you a sense of where people are so if he is on Sublocade 300 and he's settled, his cows is going to be 0. But the move to the Buvidal, checking the cows can give you a bit more information. Having said that, things like the sleep disturbance and the craving, all that sort of psychological stuff that can happen is a little bit more subtle, but absolutely. Peggy is just asking about stretching the interval longer and longer, having sublingual PRN. Yeah.
I'm always a bit worried about PRN use, but certainly the stretching of the injection interval is great. That's good. Switching over to sublingual and stretching out, second daily, that allows you to drop the dose. You've got a lot of doses that you can go down to when you're on Suboxone as well, and ultimately onto Subutex if you really need to do that fine tuning at the end. But I've never used PRN use of buprenorphine. Any comments on that?
I certainly used to do that a little bit, not PRN, but I used to do like that reducing dose of sublingual buprenorphine, and had a couple of people where they're saying goodbye at 2 milligrams a day was just really hard for them. And so it is off label and it is non-PBS, but we'd go down to the 0.4, but even then they'd be saying, oh, I'm a bit anxious about this. You could use Temgesic. You could try Norspan, but really, once again, they are off label and they are not PBS. Covered by the PBS. So there's a cost there. Emma, I'm really interested. You're starting people on Sublocade with informed consent to get serum levels up and get people comfortable, still using direct to Sublocade inductions. I mean, certainly my experience with Buvidal is that it's very quick to get people comfortable. I had a lass just yesterday, 22-year-old at a cows of 27 when I saw her. We started her on Buvidal, gave her 16 milligrams of Buvidal. Within 2 hours, she said it's magic.
Right.
She was back on track. But I'd really love to understand the thinking behind continuing to do Sublocade when there's the idea that you get those serum levels up and then you transfer them to Buvidal.
Yeah, you're still sort of left with the problem. There was one occasion recently it was a recommencement of Sublocade, and I can tell you the reason for that. It was because the patient said, I'm absolutely not going on anything else. And so we just thought, okay, it would buy us time to be able to get her used to what was the inevitable and give us time to try and get her on board with changing to another ODT. So that's the one instance where we have done that.
And just responding to Jalal, is it possible to have Buvidal 160 at lower interval than 3 weeks? Yes, it is. Absolutely is. And clinically, it's appropriate. But you're right, it's not standard policy. And you could certainly do it at 16 days. However, that is outside the PI. It is outside PBS, and it's probably outside your jurisdictional regulatory rules. In New South Wales, we can apply for those and for high dose option. It's not tricky. I don't know what it is in other jurisdictions.
And so some excellent comments coming in. So people are obviously doing this with a lot of their patients. So Alison has said, I would not add in Suboxone if the goal's coming off the Sublocade. So what's been happening there is they're just stretching out the interval of injection, I think is what she's saying, with the view to coming off Sublocade for patients who are ready to come off treatment. I assume, Alison, that's what you're saying.
Yeah.
That group who might be ready to come off treatment.
Yeah. Ready to complete.
Ready to complete treatment.
different to jumping off or just suddenly ceasing. It's a planned transition to an opioid mostly free life. Marie, I do absolutely acknowledge that for some people, just having that I can have that strip just in case, and it's more around the anxiety and the fear that I'm going to experience withdrawals. Withdrawals are awful. People hate them, and the psychological support that people can feel from having that extra strip. And you're absolutely right that you just need to look at the risk profile of the individual that you're seeing. It's a wide range of risks, and if you know that someone there is not a risk, from providing PRN, then absolutely. But you really want to have a really clear plan. When are you going to use this? What are you going to use it for? Let's keep checking in and support you, because quite often they won't need the strips. It's going to be okay. Okay, we've got 3 minutes. I think that's the end, isn't it? We haven't got anything more, Jess, to...
We've got some information on resources, haven't we? I think, Jess, is that right?
We have a slide on this is from the New South Wales Health, which I'll also include this link to the page in the letters of attendance that I'll send out to those who are joining us tonight. And I'll also include this on the OTEP website. I believe this page will be updated once the guidance has come out.
As soon as it's signed off, we'll get it up there. So look, thank you everybody for your attention. It's an important area, and it will be okay.
Yeah, thanks everyone for your participation. Nice to chat online.
Thank you everyone for joining tonight. And thank you again to Dr. Wilson and Dr. James for your presentation and sharing all of your knowledge. We're excited for the guidance to come out. And thank you to everyone for joining tonight. Have a good night.